Hi, everybody. So, in this module, we're going to be talking about some of the co-occurring conditions with autism spectrum disorder. Essentially, what we're going to do is kind of start first by giving a little bit of an overview and then just talking about overall challenges, not necessarily conditions. After going over that, kind of more foundational types of information, we're going to go into more detail on actually co-occurring comorbid conditions with autism spectrum disorder. So, one of the kind of general topics I want to discuss before I get into the rest of the lecture is that a bit of a reminder that with autism spectrum disorder, we're already talking about what I'm sure most of you probably understand by this point in the semester is a very complex disorder. There are many different facets to it, and indeed, it is kind of a disorder that's a little difficult to kind of really clearly define because there's so much complexity to it. Now, adding to that complexity are when we start talking about these comorbid conditions. Those are definitely things that can kind of make it a lot more difficult to distinguish, especially from a clinician standpoint. If you're looking at somebody, if you're looking at a client, you're seeing a client, kind of drawing that line between what is the ASD and what is maybe another co-occurring disorder. It is interesting, though, that most people with autism spectrum disorder don't just have autism spectrum disorder. It is very, very common for those with ASD at some point in their life to also have some other disorder or condition, whether that is a mental health one or it is a medical, physical disorder. To kind of narrow it down also, and a little bit of a refresher, I know I talked about this earlier in the semester, but co-occurring disorder, or what we oftentimes call comorbid conditions, are two or more conditions or disorders that have a higher risk of prevalence. So in other words, if you have one, you're at a higher risk of having the other. But don't think of it as necessarily being causal, right? So comorbid conditions aren't necessarily causal. Sometimes they are. So, for example, for medical conditions, those with really high incidence of obesity are at higher risk of diabetes. And in that case, the high fat content in their body, the high BMI, can lead to an increased incidence of diabetes. In that case, it's causal. In other cases, we don't necessarily know if there's a causal link, or at least we're not aware of what that causal link is. So, really, when we talk about comorbid conditions, a lot of times it's really kind of relying on statistics. And in fact, you'll kind of see as we go through some of these slides, the stats seem pretty high. One thing I do want you to know as we go through the rest of this lecture, though, is when I give a stat on here, that stat is for individuals with ASD. So, for example, if I said something like 30% of people with ASD have major depressive disorder at some point in their life, that is just for the ASD population. The opposite isn't true. So it isn't like you could say, well, if 30% of people with ASD also have major depressive disorder, that must also mean that 30% of people with major depressive disorder also have autism. It doesn't work like that, and those aren't the stats that I'm giving. I'm just focusing on our population, which is those with autism spectrum disorder. Obviously, kind of talking about some of these different challenges, comorbid conditions, is important because, as I mentioned, it does have an impact on diagnosis. It also has a big impact on treatment. Now, we're not going to really talk too much about treatment in this lecture. That'll be up for a later lecture in the semester. But that has been a recurring kind of theme in a lot of research is to focus on how we can best kind of change assessment criteria and treatments, especially when we talk about psychotherapies for individuals that have ASD, because we found some of the more traditional assessments and treatments that are used for the general population aren't as effective with those that have autism spectrum disorder. That's not uniformly true, but it's mostly true. So, for example, I'll talk about CBT a lot today. Briefly, but I'll talk about it with a lot of different conditions. CBT has actually had a pretty good track record with individuals with ASD, whereas other types of treatment modalities haven't. Because of this complexity, there is this element of misdiagnosis, overdiagnosis, and what we call diagnostic overlap. So misdiagnosis is that, sometimes people just tend to see something as being several different disorders or a different disorder. And in fact, in the DSM, there's a whole section at the bottom of every disorder that says differential diagnosis. And it's really meant to kind of highlight that while you're talking about ASD, there's elements of it that may look like these other disorders. And this is the key part. This is how you tell them apart, right? So it actually say in there, like, how do you distinguish between OCD and ASD? And indeed, for some of them, you can have where you have both, right? That's what we're talking about today. OCD and autism spectrum disorder is a good example of that. A lot of people do genuinely have both of those. But there's elements of both of those that kind of are similar to the diagnostic criteria of the other. So that's when we're talking about this diagnostic overlap, right? It's where the diagnostic criteria of one disorder, some of the symptoms that need to be present are also present with another disorder. Now, the element of overdiagnosis is really important here, and there's been some studies, there certainly has been a lot of push with those in the neurodivergent community that overall, Western medicine, modern medicine, including mental health services, have a tendency to diagnose. We kind of come from a culture that we put labels on a lot of different things. And there is ongoing research that has shown that, if somebody has autism spectrum disorder, once you have one label, it's kind of a bias that people have of adding additional labels, of adding these additional diagnoses, even if maybe sometimes it's not totally appropriate. So it's worth remembering kind of what we talked about way back at the beginning of the semester. Remember, it's not just that, you meet diagnostic criteria. One of the big components for any mental health disorder, at least that's what I can speak to as mental health disorder, is that you also have a significant impact in your life, right? So something like specific phobias that I'll talk about a little bit later, very briefly. I had a fear of snake when I was growing up. I got bit by a snake. I had a horrible fear of snakes throughout most of my childhood, teen years, into my early adult years. I could say at this point I'm still not really crazy about them, but I've gotten a lot better. When I was a kid, if I even saw anything that kind of mimicked a snake, like a hose on the ground or like tree roots, if I was walking through the park, how they kind of snake through the ground, it would really like give me a shock. It'd make me kind of startled. I'd be really scared. Um, would that meet the definition of a specific phobia? Probably not, honestly, because I still was able to live my life. I was still able to go to school as a kid. I was able to go to work as a teenager and as an adult. So, that really didn't reach what we call a clinical level, right? If I was unable to live my life because I had such a crippling fear of snakes, that's kind of where we would talk more about it being a clinical diagnosis. Now, sometimes that's an arbitrary line. You see some clinicians that will just diagnose regardless, but it is worth remembering that is kind of the cutoff between what's considered just normal everyday experiences. We all have anxiety, we all have depression, we all have these states versus it becoming more of a clinical diagnosis for something. So just something to keep in mind. And that's that bottom bullet point here that talks about a clinical definition versus a normative symptom. It's perfectly fine for everybody to have anxiety from time to time, whether you have autism spectrum disorder or not. That doesn't mean that you have a condition or you have a disorder. It just means you're a human being. It's when it reaches that level of where it's actually impacting your ability to live your life in some way, shape, or form that it becomes a disorder. So these first few slides that I'm going to go over aren't actually disorders, right? So you won't find these in the DSM. They're really more of challenges that many people in the ASD community face. The reason why I'm going over them first is that they also kind of can play a role in leading to the development of some of the disorders and or make those disorders worse. So I kind of wanted to talk about these first before I start going into specific disorders. So the first one on this list is autistic burnout. So when we use that term burnout, usually what we're talking about is a deep fatigue that results from long-term exposure to challenging situations from which there's no adequate time for recovery. There's lots of different types of burnout. Probably the way you've heard that term more than others would be something like job burnout. Where maybe you're working a really demanding job. I knew people last year in 2024 during the hurricanes that we had. in Florida, where Pinellas County, if you worked in EMS, you worked as a first responder, you worked in law enforcement. Some of these people were on duty for many days, working very long hours in kind of challenging conditions. And at the end of that, they started feeling a little bit worn out. They felt tired. They felt really fatigued. They had this job burnout. Sometimes you see where this burnout happens for new parents because they're so focused and kind of dealing with the challenges of having a young child, especially if that child may be a little bit fussier, not sleeping well, or maybe sick, or something like that. It can really add up. Now, when we talk about autistic burnout, what we're talking about is really the stress of having to maintain, kind of going back to what we talked about with those masking tendencies that some people with ASD have. Um, and remember, a lot of times that masking isn't an intentional thing so much. It's more of a kind of involuntary automatic response a lot of people with ASD end up developing as a way to just kind of fit in, to get along with people around them. But even though it's more automatic and may not necessarily be fully voluntary, because think about it, some people with ASD have been having to mask for maybe 10, 15, 20 years, especially when you start talking about adults and teens. Where you see this come up sometimes, though, with individuals with ASD is when they have to be in social settings. So specifically things like work and school, right? So if you want to, eat and be independent and have a house, have a roof over your head, you need to work. Well, if that work is forcing you to be in social situations that is really demanding and forcing you to mask quite a bit if you have autism, then that's going to be something that's probably going to wear you down very, very strongly, especially when you have to do it day in, day out, week after week, month after month. These autistic burnout symptoms specifically, can last a long time. They can take a long time to build up also. But they can kind of lead to a lot of the mental health challenges and disorders that we'll talk about later, in particular things like social anxiety, depressive disorders, things like that. The next element I'm going to talk about is emotional dysregulation. And this one's kind of interesting because it's not actually part of the DSM criteria for autism spectrum disorder, right? So it's not like it has to be present. However, if you read the DSM, it is mentioned as a common feature. So it doesn't have to be present, but it often is present, and is not necessarily part of the disorder itself, but rather kind of a secondary symptom of the disorder. When we talk about emotional dysregulation or instability, in mental health at least, oftentimes we use the term lability. So that refers to a state of being easily changed or unstable. So if you were talking to somebody where maybe 1 second they're really, really happy, and then the next second they're really stressed out, and then a little while later they're fearful, and then they're upset and depressed. They're kind of going through these rapid cycles of emotions. That would be lability. Oftentimes, this is a reflection of someone with ASD being overwhelmed, oftentimes through sensory overstimulation. And the net effect here is that it can lead to emotional outbursts in some people with ASD. Um, so it's worth noting on this, and I think the textbook actually even isn't really fully clear on how they say this, but it kind of makes it sound like people, especially those with ASD, experiencing this type of emotional dysregulation or lability can be violent. And it's not violence in the way that you think, and it's not even common, but it's more like if you're really, really upset and you're really, really overwhelmed, sometimes you just focus so much on trying to make that go away that you may do something kind of unintentionally that could be construed as being violent. And that's quite a bit different from somebody who has an intention of committing violence on somebody. So there is a distinction that needs to be made there. And of course, most people with ASD often don't even experience that level. They have the dysregulation, but they don't have any kind of violent outburst or anything like that. A term that's really important for you to know is this neurocrash. It's not frequently used, but you will see it mentioned in ASD literature and within the community. And it's just an important concept to know. So it's a term that is sometimes used to describe a very strong emotional response in those with ASD being overstimulated. This can lead to either activation of a fight or flight response, kind of what I was saying, right? If you're just really, really overstimulated, you may just kind of want that to go away. You're just trying to do something. You may kind of unintentionally engage in something that may be viewed as being violent. Or it can also lead to just sort of the opposite reaction, right? Where you just shut down. Both of these aren't great, right? We don't like those. But oftentimes what happens is, if you're just so overstimulated, you kind of have to do something to cope with that reality. And all of us have an element of this from time to time. It's worth noting, right? It's just a level of the threshold, right? So if I am in a really crowded restaurant, maybe I'm working and I'm stressed out already, and everybody's yelling at me, and it is just nonstop, and it is just loud, and it is hectic, I may have a neuro crash where I just want to like get out. Like I just need to leave. I need to walk out. Like I'm gonna push people out of my way to get out of that restaurant. Or I may just sit there and kind of like zone out and just like shut down. Um, that may be considered what would be like a normative response in that situation. But remember, threshold difference, right? So those with ASD, their level of being overstimulated to that point may not be all those things I just mentioned, but it may just be something like, certain lights, certain sounds in their environment that to other people who don't have that challenge, may not even see as being a problem. So moving on to talk about elements of empathy with individuals with ASD, this is kind of a very interesting topic because it's often a misconception. Frequently, people who don't have ASD kind of judge uh, or stereotype people with ASD as being kind of like unemotional, detached, lacking any element of empathy. And in fact, I've even heard people talk about ASD as being defined as not having empathy for other people, which is completely not true. There are other disorders in the DSM that would be true for, like antisocial personality disorder or narcissistic personality disorder, but with autism spectrum disorder, it isn't. And in fact, oftentimes individuals with ASD actually may have the opposite as being true, right? Many of them do have full capacity to show empathy. And in fact, some have a greater than what would be considered kind of normative level of empathy, especially in certain settings and for specific topics or interests. And in fact, oftentimes, this can be a point of burnout or emotional dysregulation. And you do, in fact, see this quite a bit sometimes where really intense elements of empathy can lead to that neurocrash that I was just talking about a little while ago. And that's especially common if you pair elements of empathy with sensory disruption. So, like the examples you see here are really good ones, right? So, a crying baby. If you have a baby who's just crying and consolable, there's a sensory element to that because you're hearing this crying. Most people kind of have an innate instinct that if a baby's crying, you kind of want to do something to help that baby. So intense empathy, paired with just the sensory element that like there's a loud noise going on. Barking dogs is another really good example. Sometimes you see this where it could be something like an injured pet where the pet is making like yelping noises or something like that, and it can lead to this really strong reaction in some people with ASD. There's a term for this. It's known as RSD or rejection sensitive dysphoria. And that's usually used when we talk about attention deficit hyperactivity disorder, ADHD, which we'll talk about later in the lecture today. But it refers to a rapid emotional response that is frequently the result of feelings of things like rejection, disappointing others, or general feelings of failure. And that's failure from the sense of the person themselves, that they feel that they had failed in something. Oftentimes, you do also see this, even though it's been something that's really more specific to ADHD. We oftentimes do see this, though, with some individuals with autism spectrum disorder. And indeed, some people with autism have referred to their own experiences as being very reminiscent of this, where if they have those feelings of being rejected or disappointing other people or failing in something, that they kind of have this very intense kind of knee-jerk reaction of taking it very personal, and that in and of itself can kind of lead to a neuro crash also. So alexithymia is the next topic I'm going to talk about. And in some ways, this is going to be kind of, to some of you, maybe contradictory to what I just said in the last slide. So alexithymia refers to a condition in which people have a greater difficulty in describing or naming their emotions. Just like the other things I've talked about here, this is more of a challenge. It's not an actual disorder. You can't be diagnosed with this. It's actually more of a symptom of a lot of different disorders and just overall mental states. Now, alexithymia isn't universal in individuals with ASD, but it also isn't really uncommon either with them. And for some people, that is the result of just their autism. For other people, it's more of like a secondary thing as a result of stuff like trauma, which I'll talk about in the next slide. The element of alexithymia, though, is you do have to kind of determine, like, is this present or not? Because it can make it a lot more difficult to diagnose and to treat individuals who have emotional or mental health challenges. And just think about that for a second, right? Your ability to not say, like, I feel sad, I feel upset, I feel angry, I feel happy, I feel whatever, can be really a big barrier if you're trying to determine if a person has depression or if a person has an anxiety disorder or something like that. Um, More frequently than not, and again, this alexithymia isn't just confined to individuals with ASD. So oftentimes, it is also seen in the general public. Sometimes it is a result or even an element of a disorder, of a mental health disorder. But more times than not, at least in my experience, it's also the result of just of trauma, right? So ASD, non-ASD, you experience a really traumatic event. Oftentimes people do experience this alexithymia, and it kind of makes sense when you think about it, right? Because a big element of trauma and post-traumatic stress disorder is experiencing really strong emotions tied to that memory. So kind of shutting down and detaching yourself from those emotions or emotions in general can be just a way of coping. So the topic of trauma and post-traumatic stress disorder, but specifically trauma in autism spectrum disorder, is honestly a very interesting topic, and it's one that could take up way more than just one PowerPoint slide. Trauma and PTSD specifically are not necessarily considered quote unquote co-occurring disorders or comorbid disorder when we talk about PTSD with ASD. However, it is actually quite common for those with autism spectrum disorder to experience trauma, oftentimes very significant traumas, especially early on in their life. And oftentimes when we talk about those, we refer to them as ACEs, ACE. So it stands for Adverse Childhood Experiences. Um, those can be what most of us may consider to be a trauma. For example, something like really severe child abuse, right? Regardless of if you have ASD or not, most people would understand that to be a trauma. Um, the interesting element of trauma, though, with people with autism is that sometimes their autism diagnosis can actually lead to some of these adverse experiences. And it can lead to them experiencing somewhat quote unquote normative experiences in an adverse way. So I'll kind of unpack that by going over some of these examples. It says here they do have individuals with ASD have a higher rate of exposure to a wide range of traumatic experiences in childhood above those of the general population, including family conflict, bullying, contact with law enforcement, and violence, among others. So let me unpack this a little bit, right? Family conflict. Well, if you are a child who has a very severe low functioning form of autism spectrum disorder, that could lead to tension and difficulties within the family, which could spill over into arguments, physical violence, things like that. So in that sense, I don't want to say it as like the autism causes family violence, but it can act as sort of a catalyst to some of these things. Bullying, obviously, is another element, right? For sadly, kids with ASD, they are bullied more frequently than kids who don't have ASD. Why? Well, because honestly, the blunt truth is kids oftentimes are learning social norms and social roles and standards. And if you don't fit in, you act in a way that they view as being weird or bizarre and standing out, they tend to zero in on that and pick on you. And kids with ASD oftentimes do stand out. They don't necessarily fit in. So there's that added pressure. So you can kind of see where I'm going with some of these things. Another interesting element is that this idea of adverse childhood experiences and trauma and autism also include things that we may consider as being non-traditional traumas or non-normative experiences of trauma. So, for example, sensory overload, right? If I'm in Disney World as a kid, as a 6-year-old, I don't have ASD, I may be looking at as this is the greatest thing ever, right? There's crowds everywhere, there's noise everywhere, there's things to see. This is the best day of my life. Well, if I'm really hypersensitive to those types of stimuli and I have autism spectrum disorder, my first day going to Disney World may be a traumatic experience. And I may experience that as other people who don't have that condition would experience what would be considered, a trauma pretty universally, like acts of violence. So that's kind of an interesting element to ASD that you don't really consider in other aspects of trauma. Alexithymia, as I mentioned in the previous slide, right? If that's present, it does make it a lot more difficult. It's not impossible, but it is a lot more difficult to diagnose and to treat, especially when we're talking about trauma. And if it gets to that point, post-traumatic stress disorder. It's worth noting, this isn't a class on psychological disorders or outside of ASD. But the distinction with what makes PTSD isn't just that you experienced a trauma. It's that you experienced a trauma and then experienced associated symptoms of that trauma. So things like disruptions with sleep, being hyper aware of your surroundings, having a startle response, things like that for more than a month after the event, right? It's perfectly normal for anybody who's experienced an event that's considered to be traumatic to have those reactions a day after, a week after, maybe even 2 or 3 weeks after. It's when it continues to stick around that it becomes an actual disorder. Keeping in mind all these things, whether a child has or an adult with ASD has a diagnosis of PTSD in addition, it is worth keeping what we call a trauma-informed mindset, or sometimes you see this worded in different ways, like trauma-focused care, trauma-informed care, I think is probably one of the more common ones. So what that means is it's just mindful and being aware of the significant role that traumas play, both in causing certain disorders, exacerbating certain disorders. There's a saying I heard before that if trauma didn't exist, the DSM wouldn't exist. I think that's kind of an oversimplification, but certainly trauma plays a very significant role in our mental health. And that's especially true with ASD. All right, so moving on, I'm now going to start talking about actually comorbid conditions. So I'm going to be talking about actual disorders. So that's going to be the shift. In these previous slides, I focused more on just sort of like general challenges that were actually disorders, although they play into many of the disorders. So the first on our list is probably one of the biggest misconceptions with autism spectrum disorder, besides what I mentioned before about that they lack empathy, and it's an intellectual disability. So intellectual disability, this isn't my words and you shouldn't use this, but just to give you a reference, not that long ago, this is what would be termed mental retardation. Oftentimes there's a misconception between, and kind of what I consider to be a conflation. So oftentimes I think people that don't know these disorders tend to kind of mix up and combine Down syndrome, autism, and intellectual disability as just being the same thing. And they're not. They're each quite distinct and different. You can, though, have one or the other. You can have both. You could have even all three. So when we talk about intellectual disability, what we're really talking about is a low IQ score, and that's one element that then leads to basically disruptions in the way a person's able to live their life. So one of the things with intellectual disability is we tend to over focus on IQ scores. That is part of the diagnostic criteria, right? You have to have a low IQ score. But the reason why I'm kind of making a distinction on this is that I have seen people who have had low IQ scores below what would be considered a normative standard, and they function very, very well, right? They're able to hold jobs, they're able to go to school, they're able to basically make the most out of what they have. That person wouldn't be considered to have intellectual disability solely because they have a low IQ score. IQ assessments, tests have historically been notoriously biased. So we can't just have that as being the only standard. Conversely, by the way, I've seen people with high IQ scores, like very high, that can't tie their shoe, right? So again, it's not the only standard, but it is a key component. When we're talking about intellectual disability with autism spectrum disorder, remember the wide varying nature of autism spectrum disorder. And kind of going back to some of the terminologies that we've used way back at the beginning of the semester, it's in the book by Durand, is the distinction between, Kanner type autism versus like Asperger's type, or what we now would term more of like lower functioning is that Kanner type, and the Asperger's type is more of the higher functioning. So the element of intellectual disability in those with significant impairments from ASD is quite high. So within that population, which now we talk more about levels of functioning. Remember, there's 3 levels of functioning. Level 1 are those individuals who have the need for the least amount of treatment for their ASD symptoms. Level 3 are those that need the most, right? So those who have a level 3 functioning, it's about 2/3 of that population also have intellectual disability. I'm making a real clear point of making a distinction here, though, because on the opposite end of the spectrum, when we talk about people with level 1 functioning, or what that book termed Asperger's type ASD, those individuals actually have a far lower rate of intellectual disability, and generally their IQ scores, when we look at the general population, their IQ scores are higher than the general population as a whole, generally speaking. So definitely something to just kind of keep in mind. Can it still happen in those with that Asperger's type ASD? Of course. It's very rare though. And remember, having autism does not mean you have intellectual disability, and vice versa. They are distinct disorders. One thing that's kind of interesting, in the next slide, we're going to talk about epilepsy. So those with intellectual disability and autism spectrum disorder are at a much higher risk of epilepsy at some point in their life, but especially in childhood and adolescence, than the average population. Treatments for intellectual disability, and you'll see this on each of the slides as we progress with the actual disorders. I'll talk about some broad elements of treatment. I'm not going to go into crazy detail about treatment because we will be talking about that later in the semester. But really the focus of treatment for those with intellectual disability is on fostering kind of independent living skills into the intervention. So it is more of what we call like solutions focus or problem focus types of strategies. Ways to find workarounds so that the person's better able to live a more independent life. So I mentioned epilepsy in the previous slide. Some of you may be familiar with that term, some of you may not. So epilepsy is a chronic neurological disorder that's characterized by sudden surges of electrical activity in the brain, which results in recurrent seizures. It's worth noting that when you hear that term epilepsy, it's oftentimes used. It's what we call an idiopathic diagnosis. So what I mean by that, idiopathic, is we don't know. So usually when a person is diagnosed as being epileptic, it doesn't just mean they have seizures. It means they have seizures and we don't know the cause of the seizures. Because usually what happens is if a person is experiencing seizures, they're going to do CAT scans, they're going to do MRIs, they're going to try to find the source of it. If it's an a nutrient imbalance, because sometimes if you have electrolytes that are out of whack in your system, that could lead to disruptions in that electrical signaling in your brain that can lead to seizures. Frequently, it's things like brain tumors that can lead to those seizures, right? So if you're having a seizure, they're going to go through the list of trying to find out what's the cause of that seizure. If they can't find anything, then oftentimes you're kind of given that term, that diagnosis of epilepsy as a default. And it really does kind of largely mean we don't know. And in keeping with that, why is epilepsy more prevalent in the ASD community than the average population? You guessed it, we don't know. But it is. Some estimates range from about 22%, seems to be about the average, about 22% of those that have ASD will experience recurrent seizures at some point in their life, usually starting about age 10, and usually becoming worse as we go into adolescence. You see here that the range is everywhere from 5 to 46% lifetime. So what I mean by the range on that is some studies say it's 5% all the way through to 46%. They're not very precise. And some of the issues with that is really having that diagnosis of ASD not always being present. You look at in the past, not as many people were diagnosed with ASD as they are now. If you're looking at a study from the 1980s, is that still comparing apples and oranges, seeing as how the diagnostic criteria changed? So there's some issues with it. That's why there's a wide range there. But it's pretty well accepted at this point that there seems to be an increased risk of epilepsy in those with ASD. And in fact, more recent studies have suggested that that risk is about 10 to 30 times higher in ASD than it is in the general population. It is kind of worth noting in some cases, it seems that kids just kind of grow out of it, that it's not as common in adults as it is in children, and definitely not as common as with adolescents. But again, we kind of don't know the cause, we don't know the connection, so it's difficult to draw correlations there. It also tends to seem to be more common in females with ASD and in those who have lower cognitive functioning. So as I mentioned in the previous slide, those with intellectual disabilities. Also, it seems that poor verbal skills play a role, although oftentimes if you have ASD and you have lower intellectual functioning disabilities, you're oftentimes more likely to be have poor verbal skills or even be nonverbal altogether. So we're not sure if that in and of itself increase the risk or if it's because it is more common in individuals with intellectual disabilities. Generally speaking, if you have ASD and you have epilepsy, it is associated with poorer long-term outcomes. And the key here is really early identification and early treatment. And with that treatment, it is screening, right? So it's making sure you don't have a brain tumor, making sure you don't have some kind of chemical imbalance within your body, within your brain, that there's not some other condition causing the epilepsy. There is medication treatments that are used to help kids not have these seizures. And it is worth really noting, when you have a seizure, you are damaging your brain. Sometimes in a very significant way, sometimes in a less significant way, but it does lead to brain damage. So that's why early identification and early interventions are really, really critical. Plus, you're at greater risk of death because imagine if you're an adult, you're driving a car, you have a seizure, you're going to crash. Just the act of having a seizure, usually involves falling if you're out somewhere. Not always do people have kind of warning signs, what are oftentimes called auras, of having a seizure. So all these can kind of increase the risk of injury and unfortunately death. So that's why the early intervention is so key. So moving into some mental health aspects, we're going to talk first about anxiety disorders. And anxiety as a whole is quite common in individuals with ASD, with about 50 to 80% of those with ASD reporting issues with anxiety. It's worth noting, though, I'm kind of going to go back to what I talked about earlier, right? If it meets the diagnostic threshold, though, of becoming a clinical disorder, right? We all experience anxiety. is it having such a significant impact on your life that it's causing you to not live your life? So just kind of be mindful of that. Some clinicians will say, well, if anxiety is present and you say it's a problem, and that's it. Others a little bit more, and the trend now is to be a little bit more analytical and kind of looking at that and making sure it meets the criteria. You'll still get treatment regardless, but as far as making a diagnosis, um, anxiety can be both a symptom, but also a co-occurring disorder, right? So it's not part of the diagnostic criteria of ASD, but when you just think about kind of secondary to the diagnostic criteria, right? If you have issues with social situations, if you have issues with communication skills, things like that, anxiety is going to come along the way. So that's what I mean by it can be a symptom of ASD, but it can also be its own disorder. And the connections are kind of interesting. I'll talk about them as I go into the specific disorders here in the next few slides. Some studies looking at the kind of biochemical aspects to this have noted that individuals with ASD seem to have different rates of regulation of their cortisol levels. So cortisol is a stress hormone. It's released by your adrenal glands. And really what it does is it kind of alters the way your body functions based on stress, based on anxiety, kind of like in anticipation of an activation of that fight or flight response. So when your cortisol levels are high, it does things like increases respiration, increases blood pressure, it increases things like sweating, heart rate. But more importantly, it also changes things like how your body digests food. It impairs your immune system. So it really has a wide range of effects on your body. So some studies have seen that individuals with ASD have higher levels of cortisol overall and or are hypersensitive to cortisol. So when their body releases it, it has a more significant effect on them than it does in the general population. These studies are still fairly new. Again, we don't really know the why behind it. We just know that it looks like this is present. And then it's worth noting, right? When we talk about things like neurotransmitter release and even hormones like cortisol, sometimes it's difficult to determine. It's kind of like a chicken versus egg argument, right? Because if somebody has a lot of anxiety and they worry a lot, that's probably going to lead to the release of more cortisol. So is the anxiety being caused by the higher cortisol, or is it causing the higher cortisol? So that's what I mean. Like sometimes it's a chicken versus egg argument. Oftentimes, anxiety disorders, traditionally, especially in the United States, have been treated with medications. We call them anxiolytic or anti-anxiety medications. There's not really solid data that shows that they're kind of universally effective. People are oftentimes shocked to hear that. Sometimes what happens is that people do experience sort of like a placebo effect with getting them. Sometimes people do have a legit benefit from it. But of course, many anxiolytic medications also have a very high potential for abuse. And when we look at the data, we don't really see where it's necessarily should be the only treatment. So I'll kind of reiterate this throughout the lecture, but when we talk about mental health disorders, oftentimes kind of the gold standard is that what the treatment is, what the cure is. And like there's no cure for some of these, but what leads to you not having the symptoms and being able to live with this disorder is often psychotherapy. But the key is oftentimes medication is needed early on because, for example, an anxiety disorder, if I have so much anxiety that I can't think clear, that I don't want to leave my house, that I feel like I'm having a heart attack every single day, that is substantial and that can be a barrier to me going to see a counselor. So oftentimes getting anti-anxiety medication, like something like Xanax, may not be ideal, but in the short term, that may lower my anxiety enough so that the psychotherapy can become more effective. Because remember, medications are quick acting for the most part. Even long-acting medications work a lot quicker than once a week or even twice a week psychotherapy that may go on for months, right? It takes a long time for psychotherapy to really start having that effect. For a lot of people, it may take, a few weeks or even months to even feel comfortable with their counselor. So oftentimes that's kind of how we look at it. Medication, great in the short term, maybe needed to be taken beyond that. But then the psychotherapy is really what's going to kind of make the lasting impact. Of course, I have to say that because I'm also a counselor, so maybe I'm a little biased on that. But there is a lot of evidence, a lot of research that points to that also. There's three main anxiety disorders we're going to talk about. So you see them listed here. It's obsessive compulsive disorder. We'll talk about all these in the next few slides. A social anxiety disorder, and then finally generalized anxiety disorder. It is worth noting though, specific phobias we're not talking about. I mentioned it earlier, my fear of snakes really wasn't a phobia. But that's what we're talking about with specific phobias, right? An intense fear based on a specific type of event, like heights or flying, or objects, things, snakes, being in a closed space, things like that. Those have not been studied as much, but they have kind of noticed in some of the studies in the early stage that even things like specific phobias do tend to be more common in individuals with ASD. And that kind of pinpoints that maybe there is something to like the cortisol levels just being higher in individuals with ASD generally, and leading to some of these kind of overall issues. But we won't talk about that specifically. I'm going to focus mostly on OCD, SAD, and GAD. So we'll start with OCD, obsessive compulsive disorder. This is something I've talked about at various stages throughout the semester so far. I'm going to kind of reiterate a little bit of the key points here because OCD is very comorbid with ASD. We don't necessarily know the reason why, but some estimates range from about 27 to 37% of those with ASD also will have a diagnosis of OCD at some point in their lives. So that's a very high rate of overlap. The two disorders, though, are very similar in some elements of them, though, right? Especially when we talk about like repetitive behaviors. So it's worth noting that because of that overlap, there have been some who have questioned if there really is a high rate of comorbidity or co-occurrence between OCD and ACD, or if it's just people misdiagnosing, right? So if you have a kid who has ACD, as autism, or ASD, sorry, autism spectrum disorder, and they're engaging in repetitive behaviors, some people who may not really be familiar with autism may say, oh, well, maybe they have autism, but I see that they look like they got obsessive compulsive disorder too, and they make that diagnosis without really knowing it. So just kind of keep that for what it's worth. There's also the element of overdiagnosis. So some people have this tendency of, if you have one disorder, well, you could have two disorders. You could have three disorders. There's definitely a tendency with our healthcare system to overdiagnose generally. OCD and ASD, even though they do have some overlap, there is a way to kind of distinguish between the two. And specifically, when we're talking about this, we're talking about the difference between stimming behaviors in autism spectrum disorder and compulsions in those with obsessive compulsive disorder. So generally speaking, those people with obsessive compulsive disorder experience obsessions, right? So these are unwanted, kind of disturbing thought patterns. Those thought patterns come into their minds and they cause them to have a lot of anxiety. Right? So a great example is germs. If I'm sitting there and I'm thinking, and this happened to me after I took microbiology when I was an undergrad, they talked about, I forget what the stat was, but it was something like 1 teaspoon of seawater from the ocean contains like 1 million viruses and like 5 million bacteria, and like every time you touch. So they were going through all this detail in microbiology class. And I remember after that, I was just like, oh my God, I don't want to touch anything. Right? Well, this is a common obsession with individuals with OCD, is that everything I touch is germs, it's filthy, it's dirty, it's going to cause me to have an infection, right? So that's the obsession. So if they're walking around and you're thinking, oh my God, there's so much bacteria and viruses and dirt and filth and grime and everybody's just unclean, right? It's probably going to cause you to have a lot of anxiety because you're going to want to like do something to avoid that. The actions that come about from this anxiety based on the obsessions, those are the compulsions. So if the obsession is me thinking everything's dirty, everything's unclean, there's bacteria and viruses on everything, it's just disgusting. My compulsion may be to avoid touching anything. Or my compulsion may be I need to wash my hands nonstop because I'm touch stuff and stuff is dirty and I just need to constantly be washing. Now, everybody should wash your hands, right? Things are dirty. Okay? But somebody with OCD is going to take it to a really different level, right? So this isn't somebody who's just washing their hands after going to the bathroom, after touching stuff, maybe before eating. Maybe they're washing their hands and scrubbing it hard, uh, you know, 30, 40 times a day. Sometimes I've seen people where their hands get so dry and they start to crack and bleed and things like that because they're washing it so much and they're being so abrasive in how they do it. So what happens with OCD is the obsession leads to a compulsion. Really, it's the anxiety about the obsession leads to the compulsion. And they engage in the compulsion in a way to try to lower that anxiety or do away with it. Now, that's OCD. You may look at somebody who has autism spectrum disorder, and remember, a big feature of it is repetitive behaviors. And we talked about that previously in the semester as being stimming behaviors, kind of like self-stimulating behaviors. Very common feature in individuals with ASD. These stimming behaviors often tend to be more rhythmic, and they're usually done for pleasure. Right. So it's not done necessarily because I have so much strong anxiety about a thought that I have to engage in this behavior to lessen that anxiety. Right. So stimming behaviors may be more common if the person's kind of stressed out or anxious about something, but it's not a direct like connection of serving the purpose. So what I mean is with OCD, right? I gave the example. If I'm worried about germs, I'm going to wash my hands more often. Well, somebody with ACD may be stressed out because I'm in a public place and they may engage in something like hand flapping or rocking or humming or something like that. They're not doing that to directly deal with being around people, right? Them doing that is not making the people go away. It's just there to make them feel better, to kind of self-soothe themselves. So that's what I mean by it doesn't necessarily serve a purpose. Like it doesn't serve a direct purpose in removing what's causing them to be upset. And usually it's just done for pleasure. It's something that feels good to them. Not doing it would lead to a lot of anxiety on their part. So that's a difficult distinction to make between these. And it indeed, in a clinical setting, takes really the person knowing that individual for a long time before making a diagnosis, and also kind of checking in, especially with kids, with family, before you really make that diagnosis. So it can be a little bit complicated. Individuals with OCD and autism spectrum disorder, usually that is treated long term with medication and psychotherapy. And again, it is fairly common, so don't misconstrue what I'm saying. Is it overdiagnosed? More than likely. Is it oftentimes misdiagnosed? Probably. But there is still a significant number of people with autism spectrum disorder that also have OCD. So obsessive compulsive disorder is one that we've talked about before in this class, and it's also one that I'm willing to bet most people are familiar with even before taking this class. These other two disorders I'm going to talk about, anxiety disorders, are less familiar to students, and they're ones we haven't talked about yet. So the first one is social anxiety disorder, or sometimes that's shortened to SAD, S-A-D. Be careful with a lot of those abbreviations, though. I do it on the PowerPoint just because it's kind of space limited. But there's some overlap with those acronyms. So, for example, SAD can be social anxiety disorder. It can also be seasonal affective disorder, what sometimes we call like seasonal onset major depression. So just kind of be aware of that. Social anxiety disorder is a chronic mental health condition characterized by an intense, persistent fear of social situations where a person might be judged, scrutinized, or embarrassed by other people. So worth noting here, right? We're not just talking about shyness. Remember that the clinical definition has severe impacts in a person's life. So an individual with social anxiety disorder, may not be able to go to school because they're just so terrified of the idea that what if the teacher calls on me? What if there's an assignment and I get a bad grade? What if other students make fun of me? They're unable to go to work oftentimes, right? This is a really severe kind of impact. Maybe if it helps you, you can kind of think of like shyness times two. This is one that hasn't been studied as much. In fact, generalized anxiety disorder and social anxiety disorder have not been studied as much as OCD with autistic populations. That being said, though, we believe it's probably quite common for those with ASD to have social anxiety disorder. Um, the rates kind of vary widely of what you've seen. That's why there's really not one listed here. The distinction, though, is a little bit easier to make than with OCD. Uh, Remember, like kind of social issues, disruptions is a key component of ASD, but anxiety about those isn't a key component, right? And it is a key component with social anxiety disorder. So that distinction is a little bit easier to make. Um, so oftentimes social anxiety can be a learned response from childhood. So we don't necessarily think social anxiety disorder, may be mitigated by a genetic factor like cortisol levels being higher, but we also think it's kind of a learned reaction based on experiences. So what I mean by that is kind of an example I've used many times this semester. If I'm a kid and I don't really fit in, I kind of do things sometimes that other kids may view as being bizarre. Am I probably going to get bullied? Am I probably going to get made fun of? Of course I am. Sadly, right? It shouldn't be the case, but is it probably going to happen? Yeah, it's probably going to happen. It doesn't have to take that happening a ton of times for me to start having anxiety about being in the settings where those things are happening, which is with people, which is in public, which is around other people. So you can kind of see where it wouldn't take that long for you to start to develop, that element of anxiety that is kind of key to social anxiety disorder. So while ASD has social disruption as part of the diagnosis, it doesn't require anxiety to be present. For SAD, the anxiety has to be a component, right? Obviously, it's an anxiety disorder. So that's a big key takeaway. One thing that's worth noting also, and this hasn't necessarily been studied in populations with ASD, but social anxiety disorder kind of historically has been really strongly associated with substance abuse. The reason is that, you know, kids have to go to school, adults have to go to work. Like you can work remotely, you can have remote school, but at some point, you do kind of mostly, especially in the past, have to be in those settings, or you have really significant consequences if you don't. So what happens sometimes is that people with social anxiety disorder find other ways of coping, right? Coping with that anxiety. If I can't not go to school, if I can't not go to work, then maybe if I, smoke pot the entire time I'm at work, or I do edibles, or sometimes what you see is alcohol is a big one where people will hide alcohol like vodka and put it in coffee or put it in sodas or something like that. Um, as a coping mechanism of lowering that anxiety. And those tend to be the most common is marijuana and alcohol. Now, how common is that with ASD? We don't really know, but again, with social anxiety disorder as a whole, that tends to be quite common. We're just not sure of those with ASD and social anxiety if it also is as common. It may not be because it may be that they use things like stimming behaviors instead. We're not sure. The treatment for social anxiety disorder, I'm going to sound kind of like a broken record from here on out because most of these treatments are going to be psychotherapy, especially CBT with social anxiety disorder. CBT is used quite a bit. Also, ABA can be used, different behavioral types of interventions can be used, as well as various social skills interventions. Up next, we have generalized anxiety disorder, and this is one that some people do have a little bit of, misconceptions on. So, generalized anxiety disorder is a chronic condition characterized by excessive, persistent worry about everyday things that are difficult to control and often out of proportion to the situation. So, I say it's often misunderstood. I come from a background of kind of like health counseling, and I've seen many doctors, nurse practitioners that have just said, oh, well, if you have anxiety, then you must have generalized anxiety disorder. And they'll actually diagnose people with that and then start medication. Anxiety, again, is part of life. It's part of being a human. You should have anxiety. Anxiety can actually play a really important role, believe it or not, in things like motivation, time management. Um, Generalized anxiety is at that clinical threshold, and it's where it's this diffuse worrying about pretty much everything. So with social anxiety disorder, it's specific, right? Social settings. With OCD, it's specific. It's based on the obsessions that the person has. With generalized anxiety disorder, it really is no one specific thing. It's everything. So it tends to be very debilitating. Um, it also must include some kind of physical symptoms, right? So that can be things like sleep disruption, fatigue, digestive issues, all of which, right, especially sleep disruptions and digestive issues, are very common in individuals with ASD also. So that's just something worth noting. Estimates range from about 15 to 35% comorbidity rate or co-occurrence rate with autism spectrum disorder. Now, as far as the etiology here, generally speaking, generalized anxiety disorder has been fairly well studied, and we think it has a pretty strong genetic component. Then do things like specific phobias or social anxiety disorder. Uh, Ongoing research as far as individuals who are comorbid with generalized anxiety and autism, as far as if there is still that level of genetic component behind it, we don't really know. Also, it's not on here, but generalized anxiety disorder is oftentimes more common in females. We think that's also the case with comorbid generalized anxiety and autism. Treatment. So treatment is often usually a combination of psychotherapy and medication. It can be either or. Usually a person with generalized anxiety disorder, that may be somebody who will have to be on medication long term, where just psychotherapy alone may not be a fix, but also medication alone isn't a fix, right? So it really needs to be the gold standard would be the psychotherapy with medication. Moving on to mood disorders. So mood disorders involve mood or emotional dysregulation, usually involving depression and or mania. Estimates of co-occurrence range from about 25 to 34%. It's most common mental health disorder with ASD and the general population is what's called MDD or major depressive disorder. So anxiety disorders overall, like that category of disorders, are the most common category, but as far as one of the most common actual disorders, it is major depressive disorder, what some people term quote unquote clinical depression. There's many different types of depressive disorders though. So usually we don't use that term. I've heard students use it quite a bit. Don't say clinical depression. I think where that comes from is honestly pharmaceutical ads because they don't usually say major depressive disorder or dysthymia or something like that. They'll just say clinical depression. Bipolar disorder is also quite common with those with autism spectrum disorder, and it occurs, it's comorbid at a slightly higher rate than the general population. I won't really talk a tremendous amount about bipolar disorder. This is an area where a lot of people are kind of focusing on research now because what they've noticed is that the treatment of individuals who have autism spectrum disorder and bipolar disorder is often very, very difficult. And bipolar disorder is a very severe mental health disorder. It actually leads to much higher rates of suicide and also injuries and death from accidents, from detrimental health behaviors like addictions and things like that. It actually has one of the highest rates of suicide among the mental health conditions. So this has been a really big focus, is trying to find maybe treatments, modalities that work best for co-occurring bipolar and ASD. Um, Sleep disruptions also play a significant role in mood disorders, specifically with bipolar disorder. Oftentimes, there's a whole actual treatment. I'm trying to think of what the name of it is right now. But it literally focuses on treating bipolar disorder on two elements. The first one is basically living a very strict schedule, right? So you eat the same time every day, you go to sleep the same time every day. Uh, Basically, it looks at changing kind of daily routines as being potential triggers for creating manic episodes in individuals with bipolar disorder. So maintaining kind of a schedule can be really helpful, specifically when it comes to sleep. Um, and the other element of that treatment, by the way, is dealing with kind of like social conflicts, sources of stress in a person's life. I'm going to focus mostly though on depression though. So let me go to the next slide. So as I mentioned, depression is more common in ASD. It is especially true with individuals who experience a lower level or need a lower level of support. So this is going to be contradictory to what you think, right? In the past, I talked about higher needs people, like those who are level 3, being more comorbid. In this one, it's not the people who have the higher need who are lower functioning. It's the opposite. It oftentimes happens in individuals with ASD who are verbal, who need very low support, who are generally higher functioning, the level 1 care. Depression in general is more common with that population than it is with individuals who are lower functioning. In some incidents, some rates put the incidence at as high as 65% in adults. So we think it's pretty common. That's not all major depressive disorder. It can be other things like dysthymia, seasonal onset or seasonal affective disorder, um, even things like, and this is a area of research that needs to be kind of explored, things like postpartum depression in mothers who have ASD, really, really understudied aspect. What we think is that with individuals who have higher levels of functioning, some of the aspects of the autism make the depression more likely to happen. And when it does happen, it makes it worse. So, specifically, things like rumination, intense focus on something, thinking about something. Like, in the past, I talked about that with like fixated interest on something like Legos. Well, what if that rumination, that fixated interest, turns from that to thoughts of death, turns from that to thoughts of just focusing on how bad the world is or how difficult things are. Obviously, you can see where that could probably lead to higher rate of depression and make that depression worse. And also things like repetitive behaviors that can play a role with that. So we think that this element of ASD kind of increases the risk of depression, and then once the depression happens, it can make it worse and it can make it a little bit more difficult to treat. Of course, also there's that strong social component. Kids who have ASD, adults who have ASD, are more likely to have social challenges. As a result, oftentimes they may not have as strong social supports, and we found that a really strong social support, whether it's family or friends, is a protective factor for depression. So if you don't have those, you're going to be at a stronger risk of it, and it's going to be harder to treat. And certainly when you have things like life upheavals, this is times when we start seeing where people oftentimes will develop depressive symptoms like the loss of a pet, loss of a family member, a friend, even changes like life changes, going from graduating high school to going to college, things like that. So oftentimes what we see is that we kind of think it's almost like a feedback loop, right? So the more depressive symptoms that a person has, it can lead to a lessening of the masking of individuals with ASD, which then leads to them kind of feeling more ostracized, noticed, which can lead to more social withdrawal, which can make the depression worse, which leads to less masking, and it's kind of this feedback loop, just snowballs off of itself. We have noticed that there's probably a significant gender difference in onset and symptoms, with males with ASD being higher than non-ASD males. So with females, we haven't really seen a difference, right? The rate is the same with females that have ASD from those who don't, that we can see so far. But with males, we see where it is higher in males with ASD than it is with males that that don't have ASD. It is worth noting, though, males in general, whether they have ASD or not, oftentimes underreport mental health symptoms. They're less likely usually to go to therapists. So kind of keep that in mind. Treatment. It depends on the type of mood disorder, it depends on the type of depression. Usually this kind of goes off of the gold standard though of medication in the short term to get you in, to get you stabilized. Psychotherapy, for the win, for the goal, right? That's the long term. I like to think of medication usually as being the sprinter. Psychotherapy is the marathon runner. Is there exceptions to this? Yeah. Going back to bipolar disorder, those folks usually do have to be on medications their whole life. Um, some forms of depression, you may have to be on that your whole life. Sometimes not so the case. It just really depends. But generally speaking, kind of the gold standard again is medication to be there to kind of stabilize the person so that the psychotherapy can come in and really take effect. So, kind of circling back, self-injury, suicide isn't a diagnosis, so it's not really a comorbid condition. It certainly is a symptom, but it's worth kind of talking about this. And the reason why I included it after talking about mood disorders, especially major depressive disorder and bipolar disorder, is that both of those are really strongly connected to self-injurious behavior and an increased risk of suicide. And both of those, self-injury and suicide, are higher in individuals with ASD than is in the general population. So when I say self-injurious behaviors, these are actions like head hitting, biting, pulling hair that are not meant to lead to death or great bodily harm. There's a variety of reasons as to why some people engage in these types of behaviors. And in some case, it can be sort of like a way for them to punish themselves. In some ways, it can be almost like somebody who has the alexithymia. I don't really feel anything. I feel so detached. Me pulling my hair out, me hitting my head, me burning myself, maybe the only thing that can make me feel something. I've seen that quite a bit. Usually, self injurious behaviors, when we talk about it in that term, it's not meant to kill yourself. It also isn't necessarily a cry for help. That's a big thing that people get confused on, especially with those who cut. It's like, oh, well, you're not really going to kill yourself. You're just trying to get attention or cry for help. No, it does serve a very real purpose for most people who engage in that behavior, and it's not to just get attention or something like that. Some estimates range as high as 50% with individuals who have ASD engaging in self-injurious behaviors. I kind of take that for a grain of salt though, because I think sometimes what happens is it's easy to kind of confuse some stimming behaviors or repetitive behaviors with self-injurious behaviors. So what I mean is, hitting your head. All right, well, there's a difference between hitting your head on a wall with force versus maybe hitting your head with your hand or something along those lines. And that's kind of an oversimplified example, but you can kind of see where I'm going with that. Where you define that isn't always universally accepted and be kind of misleading. Suicide rate, though. So this is something that's been better studied. The suicide rate is about 8 times higher among individuals with autism spectrum disorder than the general population. That's high enough already. But if you look at people with ASD that have things like major depressive disorder and especially bipolar disorder, it's way higher. So definitely areas that we need to spend more time and focus on better. Some risk factors, I have mentioned it already, right? So ASD being comorbid with things like major depressive disorder and especially bipolar disorder, but also things like history of being bullied, actively being bullied is a big one. Later diagnosis of ASD has been linked to a higher risk of self-injury and suicide, and overall social isolation. You also have to look at specific groups within ASD populations. So specifically, the one that comes to my mind is LGBTQ plus teenagers. They have actually looked specifically at that, and they found it is very, very high. And we kind of think it may have an element of that social isolation being compounded, right? So if I'm already kind of an outcast and I'm already not fitting in because I have these ASD symptoms, now I'm also LGBTQ plus, and I'm being ostracized by people for that, maybe by my own family, so I'm experiencing a really extreme form of that social withdrawal and isolation. as well as associated other things like, I know this isn't going to go away. It's going to be here forever. Depressive symptoms. I'm worried because I have to go to school where I'm being actively bullied, where I'm actually being made fun of, where I may have risk of being injured physically by other people. Anxiety is going to go up. So you can kind of see how these things are all kind of connected. One area of focus now, especially in a lot of research dealing with therapies for those with ASD, is looking at emergency treatments. So if I'm a kid and I have bipolar disorder and I also have autism spectrum disorder, I'm going through a mental health emergency, I want to kill myself, I get Baker Act. In Florida, we call it the Baker Act. It's involuntary treatment. I get taken to an emergency treatment place. Oftentimes, those are very bright, sometimes loud, hectic, chaotic places. That's bad enough in and of itself. But if I have sensory issues, is that going to exacerbate the problem? Yeah, it's probably going to make it way, way worse. Um, Assessments that are used, oftentimes are broad assessments. They're not specific to ASD. So that's another area, is looking at specific assessments and treatments that combine ASD with other comorbid conditions, especially in this case, things like suicidality. All right, folks. So I am saving the most common, probably the biggest ones for last, other than OCD. That's a big one. But ADHD. So stands for attention deficit hyperactivity disorder. It is one of the most common mental health disorders in childhood and adulthood, right? So very, very common, both in the ASD population and in the non-ASD population. However, when we talk about co-occurrence, comorbidity, ASD and ADHD are very, very, very comorbid. In fact, most estimates range between 50 to 70%. And that's looking at the autism community, right? Not the ADHD. So it's less, right? So if I look at everybody that has ADHD, how many of them also have autism? The number is lower. I think I've read it's more like 10 to 15% or something like that. But with the autism community, about 50 to 70% will have a diagnosis or have symptoms of ADHD at some point in their life. So very, very comorbid. It's worth noting there's some misconceptions about ADHD. Probably one of the bigger ones is that it's a learning disability. It's not a learning disability. It's a neurodevelopmental disorder, so similar to ASD in that regard. And it's worth remembering that because instead of thinking of it as being just, a problem that's contextual in certain areas, like learning disability makes it difficult to learn school. It's disruptions in the way the brain functions that can be holistic, that can have general, widespread disruptions throughout a person's life overall. There are several different types of ADHD too. So it's not just one type. There's actually 4 different types of ADHD. Another thing is that oftentimes, people look at ADHD as just lacking attention, and it's not really a lack of attention, right? People with ADHD can pay attention, sometimes very intensely. It's a lack of ability to kind of control that attention and that focus, and to maintain it, and really what's causing it. It's not on the PowerPoint slide, but with kids, it's worth noting it's not just a kid who has a lot of energy. I think in the past and maybe even today, there are those who are misdiagnosed who do just have a lot of energy and maybe need to have outlet for it. But strictly speaking, that is not what ADHD is. Um, there are some shared traits between ADHD and autism spectrum disorder, like elements of impulsivity and attention, sometimes hyperactivity. So it is something worth noting of kind of taking the extra time to really making the distinction. Does this kid have ASD and ADHD, or is it just some of the symptoms kind of mimic it? As far as treatment, so there are several behavioral strategies that tend to be very effective, and are often used along with various other types of psychotherapy. Really the idea here, kind of with ASD also, isn't to just like cure somebody, but to find a workaround, right? So if you have problems with maintaining attention and focus because of this, can we find another outlet here for that'll allow you to maybe do it in smaller amounts, or find something like, these aren't really used that much anymore, but I'm just giving an example, like a fidget spinner or something to focus their attention on. Medication is still widely prescribed with ADHD, both in autism populations and outside. It is decreasing because we found that it's not really super effective. Really finding behavioral strategies is more effective. And also, there's a really high risk of abuse and addiction with many of the medications that are given for ADHD. A lot of people are actually kind of surprised to find out that some of the most common medications given for ADHD are actually amphetamines, like methamphetamine. So think for a second about how addictive meth can be, right? It's still addictive, even if it's a prescription you get from CVS or Walgreens versus on the street. It's just a little bit more controlled, better controlled, and being prescribed versus not being prescribed. Now, I am in no way saying if you need it, if it's helpful for you and you're able to maintain your ADHD symptoms with it, go ahead, take it. Of course, follow what your practitioners are saying. But it also is something that has changed in our outlook and it isn't prescribed as much and it's a little bit more controlled now. So, problematic sleeping patterns, sleeping disorders, these tend to be really common in individuals with ASD, especially among children and teens. Uh, it can continue into adulthood, and this is true also of just the non-ASD population too. Usually, sleep disorders like sleepwalking, sleep talking, things like that are more common in children, tend to be less common in adolescents, and then less common still in adults. What tends to be more common as we go into adulthood are things like insomnia. With kids with ASD, though, insomnia tends to be very, very common also. And usually sleep disruptions with those with autism tend to increase in adolescence rather than kind of declining. Some evidence suggests that autism spectrum disorder may be related to abnormalities of GABA. So GABA, it stands for gamma aminobutyric acid, is a neurotransmitter that is your brain's, your neurological system's primary inhibitory neurotransmitter. So what that means is when GABA rates are high, it decreases most, not all, but most of the other neurotransmitters. And that's a really important function because what happens is, when GABA is released, that means it kind of has this calming, lowering effect with the other neurotransmitters. So you can kind of see where that would play a role with sleep, especially onset of sleep, maintaining sleep. Also important is a hormone called melatonin. So melatonin is released in the pineal gland, so tiny little gland, sort of at the back inside of your brain. It's really kind of buried in your brain a little bit. It releases this chemical, which is a hormone, even though it's released in the brain, it's a hormone called melatonin, which plays a really critical role in bringing about sleep. So not so much maintaining sleep, but it brings about sleep. They have found evidence that GABA regulation, and especially kind of its sensitivity, isn't as strong in individuals with ASD. So they may be releasing GABA, but it may not be actually kind of, doing what it needs to do. And that melatonin also may have a dysregulation with that, where it may not be released as much, or it's released as much as it is in the average population, but its effects aren't as strong. However, just like with many things when we talk about biochemistry, it's kind of a cause and effect, chicken versus egg, right? Does lack of sleep and disruptive sleep and maybe other things like anxiety, does that cause a decrease in things like GABA and melatonin, or is it caused by? So that's something that's difficult to really determine. And in all fairness, there's not a lot of studies that have been done on the kind of neurochemistry behind sleep disorders in ASD people. It is worth noting that these sleep disorders, though, do oftentimes have a compounding impact on those with ASD. So what I mean is, if I have insomnia, I'm not able to go to sleep or I'm not able to stay asleep, I'm not getting as much sleep as I need. That may lead to fatigue, less energy. Maybe that'll lead to things like obesity, weight gain, which may further my social isolation or withdrawal. I may have increased risk of depressive symptoms because lack of sleep and depression is actually part of the diagnostic criteria is you have to have a lack of sleep for many elements of depression. So that's kind of worth noting too. One really common element of sleep disorders, sleep disruptions in ASD, especially with kids and adolescents, uh, is sort of like a disruption to their body's kind of natural circadian rhythm. So oftentimes what you'll see is that these kids will just want to stay up until like 1 in the morning and then sleep until like 2 p.m. or something like that. It really is a disruption to how they cycle, and that tends to be fairly common. And again, going back to bipolar disorder, if you remember, one of the theories with bipolar disorder is that manic episodes are brought about from things like a dysregulated schedule throughout the day when it comes to things like eating, sleeping, etc. Well, you can kind of see where these would go hand in hand then. The last component here that I'm going to go over is comprehensive uh, assessment. So because there's a substantial amount of diagnostic overlap with a lot of these conditions that I just talked about and concerns with individuals with ASD, oftentimes what we see is, we need to have very clear assessments. How are we really able to quantify, to do a test, to do some kind of, you know, objective uh, experience to know that this person has it. In psychology, especially, we don't have the benefit of a blood test to see if somebody has a condition or doesn't have a condition. A lot of times it's self-assessments. It's asking people questions, getting their feedback, or having them fill out things like a survey. The issue here is that oftentimes when it comes to individuals with ASD, those assessments aren't really that great, and they're not specific to people with ASD that may also have something like, major depressive disorder, bipolar disorder, OCD. We have really good assessments just overall for those things, not necessarily specifically for individuals with ASD. And there may be a difference on that. And that is actually an area of growing research now. Because of that, there can be a little bit of ambiguity, a little bit of difficulty in really determining, is it a comorbid condition? Is this an element of ASD? And usually what that means is that clinicians, before they make diagnoses, really should get to know their clients. That shouldn't be a revolutionary idea, but it is. They should take the time to really see all the elements of how the symptoms are affecting that client's life. Now, it isn't really done as much anymore because usually the people making the determinations of autism uh, are psychiatrists, psychologists that really only do that. So they kind of develop sort of a quantity over quality mindset. The more assessments they do, the more diagnoses they make of ASD, the more money they make, the more clients they can see. That's a little bit of a soapbox moment for me, all, but that is really kind of how the system does work. So oftentimes they don't have that ability to really sit down and get to know their client and see kind of holistically how their symptoms affect their life. There are some adapted tools or assessments that are being developed for individuals with ASD versus assessments just used for the general population. More definitely needs to be done. And there's also some treatments, some therapies that are being developed more specifically for individuals with ASD and the comorbid condition. So what I mean is not just treating a kid who has autism and bipolar disorder the way you would treat a kid that just has bipolar disorder. Right, we're getting better at developing those more specific types of treatments. We have a long way to go, but it's also a very time-consuming process to kind of develop the treatments, to tailor them to individuals with autism, and then to test to see if they're effective or not, and then to kind of get that element of if it's a reliable measure, right? So not just to get good results off one experiment, off one study, but off of multiple studies across many different ranges over time. So it just takes time. But something that we're working on and definitely an area for future research.